finished number 61, diverticulitis. Everyone remember the word is your diet, fiber, fluids you remember, and NPO. 62, appendicitis. And in appendicitis, the pain is right lower quadrant. And what is another word is called McBurney point, remember. And in the exam or anytime they're asking you, where do you assess your patient for pain? So remember, between umbilical area and right iliac crest, because may not give you McBurney point, but they're asking you where do you assess the pain? Between umbilicus, so this is your umbilicus and right iliac crest, and in between is called McBurney point. And also I want you to add the rebound tenderness. There is a tenderness and appendicitis. I want you to write down the word fever. What do you monitor? White blood count is high. There's infection. And why sometimes white blood count is high? If it is rupture, it can lead infection. What is the complication of appendicitis? Is peritonitis. All your GI, anytime perforation word lead to peritonitis. So what is appendicitis? Pain on the right lower quadrant, McBurney point, and also remember the word between umbilicus and right iliac crest. That is the area you're going to monitor for your patient on pain. And what do you do for your patient who has appendicitis? NPO. No enema, no suppositories, no food. Patient is going for surgery. 2-3 things I want you to write down for your position. Everyone should know white blood count, peritonitis, pain, and what position do you put your patient after appendectomy is you can turn them on the right side or semi-Fowler's position. 2 positions, semi-Fowler's or on the right side. Patient can turn on the right side. And also they have Penrose drain. Penrose drain are no bad, but it's like a small tubing, and it helps them to take out extra fluid to prevent infection. So patient come back, they have Penrose drain. Whenever you have Penrose drain, your position would be good semi-Fowler's because it will help them to drain. If they're not asking Penrose and they're just saying, what is the best position for your patient who has appendectomy, either semi-Fowler's or the right side, you can put it in. Pain medication is good. Assess for bowel sound, peristalsis. Assess for urinary bladder retention because it's lower part. So before you give food, what do you assess? Peristalsis. So that's enough to know on appendicitis. 63, underline the word portal hypertension, not hypotension, and also is patient has ascites. Underline the word and change the word hypertension. And what is hypertension leads to? Write down the word bleeding. Every time we move in and you start memorizing a picture of your patient. Patient who has liver cirrhosis, they're bleeding. Where are they bleeding? Esophageal varices. Write down the word esophageal. They're bleeding, they're vomiting. And what is the word is called? Esophageal varices. And second, hematemesis. Everyone should know they're vomiting blood. And also melena word. And what is the reason for patient who's bleeding? And write down the word portal hypertension. Why patient is bleeding? Portal means liver, and liver is not functioning, and all the cells are bad because liver has its own circulation, leading to portal hypertension. Esophageal varices mean they're bleeding from esophagus. And they may not give esophageal varices, and they're saying patient who's admitted with liver cirrhosis, they're bleeding. What do you monitor? Hematemesis, melena, bruising, they have even hemorrhoids, all over they can bleed, all right? So, and what is second thing is, remember, so one, bleeding, Number 2, ascites, start memorizing. What did I did earlier? Ammonia level was high. Remember that? We did in the drug. Ammonia level is high when patient has liver cirrhosis. What are the problem patient has? Bleeding. What is the reason for bleeding? Portal hypertension. Now I will move on 64. Where do we get insulin? From pancreas. What cells in pancreas are beta cells? Underline that word, is beta cells, and lead to patient with is diabetic. On your question. Number 65. When you have pancreatitis and colitis, that means pancreatitis or gallbladder, morphine you do not give. In the next line, Demerol should be given. Why? Because it caused a spasm in the sphincter of OD. So that's your question goes in your pancreatitis question and your on your pain medication. Number 66, you will go on trousers and also correct that Chavarsky sign are for calcium. What is Chavarsky sign are? Cheek. Remember the word Chavarsky, cheek. And what are you checking here? Cranial nerve. And trousers. What is trousers signs are? You are checking what muscles here? Carpopedal muscle. That was they will give in the exam. And what do you see is low calcium. And what is low calcium is causing technique and twitching of muscle. Which patient do you monitor? These two signs I did yesterday. Which patient do you monitor? Thyroidectomy patient. Remember when they have thyroidectomy? What do you lose after thyroidectomy? Calcium. Where are you getting calcium? From parathyroid gland. So remember, write down after thyroidectomy, you're monitoring patient. Patient's parathyroid gland is not producing calcium. What test do you do when you have lack of calcium? Chavarsky and Clauser sign. Positive means patient has low calcium. Negative means patient is okay. Are we clear? Because they will use those wording. And number 67. Any questions with pancreatitis? Which are the other patients you monitor in the babies? Cystic fibrosis. And what are they missing? Pancreatic enzyme. Underline the word pancreatic enzyme. When do you give pancreatic enzyme? With meals and snack. Whenever you're giving pancreatic enzyme, write down the word, you must add fat-soluble vitamin. What are fat-soluble vitamins are? A, D, E, and K. A, D, E, and K, you're going to give them with. And which are the other patients? Pancreatitis is fine, but the babies with cystic fibrosis, and you cut down the diet in pancreatitis and cystic fibrosis, fat, because they are not able to digest fat. So what do you cut down in the diet? Low-fat diet. Next is chronic pancreatitis, we said, and I want you to add there, the medication is Viocase. Viocase is the enzyme. So Viocase is pancreatic enzyme. Add there, Viocase is enzyme. Next is never give potassium in IV push. Never. And what do you check before you give potassium? Renal. And what do you check? Creatinine level. No urine output, potassium level is very high. When you pee more, what are you losing? Potassium. Which patient you pee more? DKA. Your patient with hyperglycemia. What happened, DKA? They are very high sugar. And what do you monitor? Potassium level. You're losing potassium. But when you have renal failure, you are retaining. And you never give IV push. That means straight potassium. You've got to mix it with the IV fluid and give them by the drip and by the pump. Next is mineral corticoid and Addison disease. I'll write down another medication, Florinef. So mineral corticoid and Florinef. They can give them for patient with Addison. What is high in Addison patient are? What is high in Addison patients are? Potassium. Remember, write down on the side. And calcium is high. What is low? They have sodium and sugar and blood pressure. Next is in number 70, DKA. Let's go on DKA. Highlight the word number 71. DK is rare in type 2. Type 2 patients don't have DKA because they have enough insulin and prevent breakdown of fat. So I want to explain here is when your patient is in DKA, we all immediately think ketones, which is true. Patient has DKA. Number one, which patient has DKA type 1? Everyone is okay. And when they have DKA, we all know they are having ketones in the urine. You are monitoring ketones, but keep in mind it's a hyperglycemia. What is it? Ketones. What is DKA? Patient is going in hyperglycemia. And if they give you, what do you do as a nurse? First thing, don't pick up answer to check the ketone. First thing you give insulin. What insulin are we going to give? Regular insulin IV. That's number one answer. Ketones you're monitoring in the urine. What is ketones comes from? Write down the word fat metabolized. And they don't have insulin. DKA people are insulin dependent. So what happened? The body start using fat, and fat metabolism is producing ketones, which is in the urine. So fat metabolizing and causing ketones. What do you monitor patient? Another question. What do you monitor? DKA patient is here. First thing we already know, ketones, hyperglycemia. Next answer, metabolic acidosis. They're going in metabolic acidosis. What kind of breathing they have? Kussmaul breathing. Next answer, monitor potassium because they have a lot of hyperglycemia, polyuria. When you have polyuria, your potassium level is going down. So what do you monitor patient here is monitor for potassium level, and maybe you need to also increase fluids, dehydration, and potassium. This is the way we got to memorize. Everyone is okay? Is DKA, you guys have already fat, but I want you to write down on the side metabolic acidosis, and fat is metabolizing, and you monitor Kussmaul breathing. And that means your patient needs to be given potassium. Next line, 71, is DK is rare in type 2. They have enough insulin, and you do not give them insulin. And what does it? And prevent breakdown of fat. They're not metabolizing fat. So remember two answers. Type 2, do not metabolize fat. That's a very important thing. Type 2 patients we call HHNS, hypermolecular non-keto acidosis. So they're not going in acidosis, but they have high sugar and not metabolizing fat. No metabolic acidosis, only type 1 are going. Well, how do you treat them? Basically, fluids. Very rare you will need insulin. If you give fluids, their sugar level will come down, and also monitor potassium. So those two answers are good. HHNS patient, they are not having ketones, no ketones in their urine, and they are not going in metabolic acidosis. They are not using is the fat to metabolize, and they have enough insulin, so you don't give them insulin. Basically, you need to increase the fluid. Everyone is okay? HHNS type 2 and DKA is type 1. And what are, they are not metabolizing fat. Which one has metabolic acidosis? Type 1, not type 2. So very clear, you remember like that, your questions are. What insulin do you give them? Is regular insulin. Next is 72, fat embolism. When does it come, fat embolism? Write down fracture. And what does it lead to? Pulmonary embolism. How do you prevent your patient for fat embolism? What do you do as a nurse to prevent fat embolism? What do you do to prevent fat embolism? Immobilize your patient. Immediately, what do you do? Immobilize. And what medication? So remember, is this way, fat embolism leading into pulmonary embolism. Everyone, fat embolism comes from fracture. Your patient fell. But what do you do for your patient when they fell? Your priority is immobilizing. When you're immobilizing, you're preventing fat embolism. And fat embolism, if you don't prevent, patient is going pulmonary embolism. What is the first sign of pulmonary embolism is? What is the first sign, everyone? Petechia over the chest. Small bruising, petechia over chest. Remember the word shock. They're going in shock. Remember the word hypoxia. If you will remember these three things, petechia is number one answer. When you see petechia, you know patient is going in pulmonary embolism. And what do you do when you start seeing petechia? Raise the head of the bed. Give 100% oxygen. Now, shock means the blood pressure is dropping, pulse is high, and they may give an answer. Patient has tachycardia. What is the early sign of hypoxia is? Restlessness. Early sign, restlessness, and late sign would be cyanosis and dyspnea. Cyanosis and dyspnea, chest pain, you can have shortness of breath. These are your sign and symptom. What do you do for pulmonary embolism? Raise the head of the bed, give oxygen, and also give them heparin. And you can give them morphine. Heparin should be given IV. When you're giving heparin, monitor for bleeding. So everyone should know. What are the complications of fractures are? What are the complications of fracture? Number one, fat embolism. What is number two? Pulmonary embolism comes because of that. But there's another question I want to say is osteomyelitis. Now, you guys read your question. If they tell you patient fell, patient has fracture, but patient has compound fracture or abrasion, then don't pick up first answer, immobilize. You've got to pick up cleaning of the wound. Why? Because it will lead to infection. Are we clear? Then your question totally wrong if you go immobilizing. So everyone must know when your patient fell, whether outside or in the hospital, and your questions are, what do you do? Remember, if there is no skin open, no abrasion, immobilizing is first answer. If you have compound fracture and skin is open, the bone is sticking out, and patient has abrasion, what do? You clean the wound. Maybe washing with water, soap and water is okay, but don't pick up the word irrigation. What is irrigation is totally different. You're taking a syringe and you're irrigating or you're doing, and you don't have that. So what do you use the word washing? So remember, two complications. What is the third complication of fractures is compartment syndrome. Everyone should know three complications of fractures are fat embolism, osteomyelitis, and you will have compartment syndrome. How do you prevent this? By immobilizing your patient. Heparin, we already talked about it. And I will move 73. Patient with knee replacement. What treatment do we give for knee replacement? CPM machine. Continuous passive motion. What is continuous passive motion means you're giving patient exercise through the machine. Number one, in your teaching, tell the patient he don't have to put any pressure. Machine is moving itself. And what are you giving in CPM machine? is what are we giving here is, remember, what do we go? Machine goes like this. So what is this exercise? Flexion and extension. What is your goal? What is your goal for your patient here? Is number one, to obtain or to regain maximum flexion. Are we clear? What is the hardest thing? Flexion. Everyone remember the word, to maintain complete flexion. And what do you want? Your muscle to become strengthened and strong. And what do they teach them? They go back for exercise and follow-up appointment for a long time, once a week, twice a week. And what do? They put the weights on their leg and they have to do lifting and holding the weight because they're gaining what? The strength of the muscle. Where do we use CPM machine? It's not used in the OR, not even right away, maybe after a day. There was a time we used to use right away as soon as patient comes in, but now they start waiting. Some of the patients even they're giving when they're going home because they discharge early and they send them home with the machine and they teach them to do daily exercise follow-up appointment. The meaning is your patient should be able to do flexion and the muscles should be stronger. Are we clear? That is called knee CPM machines are used. Number 74, prophylactic antibiotic. Prophylactic means preventive. Which patient do you give to prevent infection? Any kind, like dental. You go to the dentist, they're going root canal, and the risk of infection, they can give you, if it's a bad infection, antibiotic. Prophylactic means preventive. Invasive means any procedure going inside the body. 75. Glaucoma patients are having what problem? Loss of peripheral vision. And remember, even you are giving eye medication, there's still a risk for fall because they cannot see. Everyone is okay? In any question, patient is still using your miotic medication, patient is older, patient has glaucoma, what is the risk here? Fall. You still monitor them. Why? Because they cannot see through clearly. How do you treat glaucoma? Basically, first with the medication. What drugs are we using here? And what do you monitor for glaucoma patient? Eye pressure. What is the normal eye pressure is 10 to 22. So make sure you write down that. It's called intraocular pressure. And what eye drops you are giving, write down the word miotic. What do you teach them? To put their eye drops regularly and prevent them from blindness. And that's important for your medication. What are some of your medication for glaucoma you have? Mannitol, remember? We said the word mannitol yesterday. Mannitol is given for ICP and IOP. That means intracranial pressure. Mannitol can be given IV. Next is Diamox. You can give them Diamox. That's also monitor for both of them potassium, increasing urine output. And you have is Temoptic. Temoptic. So make sure start memorizing. Everyone should know mannitol, Diamox, and Temoptic, and monitor potassium. I will move on. Number 76, cataract, cloudiness, vision problem. And what do? They do the surgery, removal of the cataract. And what do we teach them to use? Eye shield in the nighttime. And prevent all your patients with coughing, constipation, bending, pain, anything you need to notify. 77, CO2 caused vasoconstrictor. 78, spinal cord injury are from cervical. What is cervical? Our neck. And lumbar are going in the back. So you have thoracic, you have lumbar, you have sacral, and you have cervical. What is the biggest problem with cervical fracture? Are airway, breathing. All your spinal cord injury patient, what do you monitor first thing? Compromising breathing. Maybe they need the ventilator, especially cervical one. And what is the complication I said yesterday from spinal cord injury? I highlight the word 79, highlight the word 80. Everyone should know, patient who has spinal cord injury, 3 problems. I want you on the write down on the side. Number 1, any question, you don't know cervical word for neck, then you have lumbar in the back, thoracic is chest, and sacral goes on the tailbone. This one very much high compromising breathing, cervical on the neck. And they are, remember, patient who has spinal cord injury, number 1, is monitor for breathing. Number 2, they are paralyzed. Number 3, they cannot empty the bladder, so problem with the bladder and BM. And what is the condition? They develop the complication. So everyone knows they are paralyzed. They live all their life and they are paralyzed. And what is second thing? We keep it in mind, the problem with they cannot empty the bladder and the constipation. And if they cannot empty constipation and they are having a regular bowel movement and for some reason they cannot pee, they have a severe problem which is called 79 is autonomic dysreflexia. Everyone remember the word autonomic dysreflexia is a complication of a patient who has spinal cord injury. And what do you monitor for your patient here? Hypertension. So first thing you got to lower the blood pressure. So let's see what you have. Autonomic dysreflexia, underline the word life-threatening. And underline the word sympathetic nervous system. Yesterday I said the word noxious stimulation. Underline the word, there is something which is bothering your patient and pain. And what does the pain leads to? Noxious stimulation, something is obstructing and pain is causing and leading hypertension. Everyone is okay? So what is autonomic dysreflexia? Complication of spinal cord injury. It's affecting the nervous system and patient has some stimulation and they use the word noxious stimulation. And what does the patient has here is hypertension. So make sure it comes from full bladder. Maybe patient is not able to pee. Maybe patient is constipated. Maybe patient is laying in a wet linen. Maybe patient clothes are tight and making him very uncomfortable. And this discomfort and pain is leading the blood pressure. Immediately when you see question, patient has autonomic dysreflexia, it's a complication of spinal cord injury. And what does the patient has here? Hypertension. What do you do? Maybe first answer, remove the noxious stimulation. Yesterday I said, what do you do first thing for raise blood pressure? Raise the head of the bed. Second answer, comfort of your patient. Make them comfortable. Number 3, check the bladder. If they have Foley catheter, check for king. Otherwise, straight catheter. Number 4, check for bowel movement. Number 5, give the medication for blood pressure. Number 6, notify. Don't pick up your answer, notify. This is a late complication. And what is the sign? Are hypertension. Now, I want you to highlight number 80. A spinal shock comes immediately. So there are 2 complications. Number 1 is spinal shock. And number 2 is autonomic dysreflexia. So which one comes first? Spinal shock. What is the sign and symptom of spinal shock? They're paralyzed but low blood pressure. Write down one thing, low blood pressure, low pulse rate, but they're paralyzed. Monitor for abdomen, for paralytic ileus. What is the word paralytic ileus? They cannot pass the BM. Are we clear? Bladder distension. So remember, there are two complications patient has after spinal cord injury. Which one has a hypertension, autonomic dysreflexia? Which one has low blood pressure, a spinal shock? When does the spinal shock comes? Right away, and stays with your patient around 3 to 6 weeks. After 6 weeks, this is gone. Patient lives with all his life, and they are paralyzed, and the problem is hypertension comes only when patient is in pain. Are we clear? Or discomfort, and that is the word is called autonomic dysreflexia. So you guys are very clear with spinal cord injury. First answer, respiratory. Second answer, they are paralyzed. Third answer, monitor bladder and monitor the BM, and spinal shock and autonomic dysreflexia. I will move on to the next is, so autonomic, we did it, and full bladder. And 80, you have spinal shock, write down the word low blood pressure, low pulse rate, check for bladder. Multiple sclerosis is what is multiple sclerosis patient has is in your myelin sheath. Underline the word myelin sheath are disturbed. And we did, I think, yesterday. And what is the first thing we have the patient with multiple, we did myasthenia gravis, but what is multiple sclerosis? I want write down few things, and it's in neuro, but those who are taking, we all are going to take exam, but this is the way to start memorizing, is myelin sheath, multiple sclerosis. Second thing I want you to add there with patient with multiple sclerosis is they start with the legs, and the word is called spasticity. This is the way you remember, their muscles are very spastic. What is the risk is here? Fall, ambulation. Your answer is number one, safety. They're walking, but they're not safe. Number two is bladder and bowel problem. In the bladder is they may have urinary retention, may need Foley catheter, monitor for UTI. Number three, BM problem. They cannot empty and monitor for constipation. Number four, vision. In the eyes, they have diplopia word. Diplopia, double vision, and nystagmus, abnormal eye movement. What do you do as a nurse? Eye patch. And eye patch, when you are putting the patch, alternate. Remember the word alternate. Don't cover eyes, both of them at the same time. Alternate. Next thing is, number five, swallowing. Now some question they didn't give anything. And they remember myasthenia gravis I did yesterday. And I said respiratory is the first problem. Here, multiple sclerosis, the first problem is your spasticity. They give you all of them. Maybe your one answer may be swallowing problem. That remember feeding, and maybe they will end up with NG2. The next one, they are very depressed. Emotional liability, depression, and emotional liability. And your answer with multiple for your sclerosis patients are. So you got to go for your patient with multiple sclerosis. Now I want everyone, definitely you guys know on your question, what is the one of the reason you will teach? It comes in early age and it flares up the disease. How does the disease flares up? If they are going out in the heat. So what do you tell them? Beach, they cannot go out in the sun and stay. So remember, in your teaching question for multiple sclerosis, avoid too much of heat, that means the beach question. Avoid also very cold and dry. This is a lot of question you will see. Disease get worse when they have infection. Disease get worse if they get pregnant. So remember, is some of your question. Patient is admitted. with acute exacerbation of multiple sclerosis. What do? Your answer is their muscles are very weak. They can't even walk, they cannot swallow. What do? Give them the rest. Everyone remember the word is exacerbation. So everyone should know properly your multiple sclerosis. 82, we did myasthenia gravis yesterday. And what is the problem? They have lack of acetylcholine. Underline that word. And what is the highest priority? I said yesterday for myasthenia gravis are eyes, weak eyes. What is the word I said? Ptosis. And the problem with breathing. So make sure highest priority are breathing here, respiratory, and also chewing problem, swallowing problem, eyes problem. Make sure number one priority, myasthenia gravis, respiratory. Multiple sclerosis, swallowing problem. Tensilon test, we said, you can give them IV, they can give IM, and what do you monitor? It's a drug, and you are diagnosing a patient if they have myasthenia gravis. It's a drug, and what happens if the muscle becomes strong, that means positive. Patient has this disease. Next is GBS. I really want to write down a few things here, and you've got to know neurosystem very well. All these diseases are very common. You see all our patients with different kind of diagnosis. So what is GBS? Guillain-Barré syndrome. Number one is called ascending paralysis. That's going from legs, same as we were talking, and going upward. What is the highest priority for your patient would be for GBS is weakening of the lower extremity, respiratory. Everyone make sure ascending paralysis, going from legs, and when it goes up, respiratory, and also cardiac. Heart is affected, very important, GBS. How do you treat these patients are? So they have cardiac problem. How do you diagnose them? They do lumbar puncture and write down one word, cerebral spinal fluid, very high in protein. That's a diagnosis for GBS. Cerebral spinal fluid, high in protein level. What treatment do you give them? Steroids. You can treat them by steroids and also IV immunoglobulin. These two are very important. So a lot of questions they ask, how do you treat them? IV immunoglobulin. How do you diagnose them? The protein is high in cerebral spinal fluid. Also, I want you to remember, how does this disease come? What is the reason in your question? Number one, it's an immune disease. So remember your immunity, immune system. Number two, allergy with immunization. Question when you do, what is the reason patient has this? Patient has last week some immunization and they got allergies. So some, number one, immune system. Number two, allergies with immunization. When they advertise in TV, every time you hear it's a season, you're giving immunization, monitor person for GBS. Number three, post-infection. What is number three? I want a patient has, post means after infection. What is post-infection is respiratory and GI. If they have respiratory and GI infection can lead to GBS. So those are very important, that three answers. I wrote it down, common question you will see on this condition. What is the highest priority? Respiratory. How does this disease comes? Allergy to immunization, immune system disorder, and how do you diagnose it? By cerebral spinal fluid high in protein, and how do you treat them? By giving IV immunoglobulin. Next is Parkinson disease. Everyone should know. What is in Parkinson are, is tremor, is first number one answer. Then you go rigidity. So tremor, rigidity, And what is the problem with the patient here with Parkinson? Number one, what kind of face they have? Mask-like face. No response. What is the problem this patient has? ADL. They're very slow movement. They're shaking. And next is very important, risk for aspiration. They're drooling. They're drooling and the risk for aspiration. Parkinson patients are. What do? Give them time. Prevent them from aspiration. And what happened? They walk, they don't lift their feet. What is the word is called? Shuffling gait. And what do you teach them? To lift, proper shoes, and teach them. And what happened? They're bending like that. So you want to keep their back straight and maybe putting them in a prone position. Medication. You give them some of your medication. Levodopa, Cinemet, some of your medication. Cogentin, Artane. Remember, I said Cogentin and Artane earlier. Levodopa, you have. Everyone remember Parkinson medication. Do not give B6 with them. Why? Because it lowered the absorption of your medication. No B6, no Maui medication. What is Maui medication are? For depression. So no Maui medication because they decreases the medication. What is the best time you give the medication? Before meals. So give them before meals. Now the next is TIA. What is TIA? Transient ischemic attack. It's a stroke, mini stroke. And what do you, the brain is not completely damaged. What do you monitor? Patient has TIA. What do you monitor? Muscle weakness. What is the word they use for muscle weakness? Flaccid muscles. Flaccid means are the weakness. The muscles are weak. Flaccid. Flaccidity. And what medication do you give? Aspirin. And what do? You notify your physician. Why? You got to prevent them from having a big stroke. Check for weakness, see if they can swallow, check if they can talk. And what is one of the reasons for a stroke is hypertension. You've got to control their blood pressure. Same 87, CVA patient, brain tissues are bad. What do you prevent a stroke patient? What do you monitor CVA patient are? It's a blood in the brain. Blood vessel rupture. What do you monitor? ICP, right down on the side. What are you preventing them from seizure? What do you monitor? Swallowing problem and speech. They cannot talk clearly. And opposite side is the weakness. Their eyes are blindness, safety, issue for your patients are. What diet do you give them? Maybe a soft diet if they cannot. And what kind of fluid you're going to give them? Thickened liquid. And make sure they're sitting upright. And put the food in a clockwise because of the blindness. And a lot of questions would be on safety. Hodgkin disease are lymph node cancer. And curable if you treat early. They have 3-4 stages. Stage 1 is very early stage. You treat them, patient can be good. Rule of 9 goes in your burn patients are very important. We all need to know about your burn patient. What is the priority for your burn patient are? Number 1, airway. ABC. Number 2, hypovolemic shock. Everyone should know. And what is the third thing you will remember? Infection. What room are you going to put? And the technique, a sterile and reverse isolation. And what is the problem with your burn patients are? Complication. What do you monitor when they have low urine output? I want you to write down, remember, in early burn, potassium. No urine output, potassium is going high. So early, as soon as your patient burn, potassium is very important, and monitor airway, and hypoxia is there. hypoxia, and what do you give them? Oxygen. 100% mask. And you will go for is your patient potassium level. What are the complications are? Hypovolemic shock, we said, infection. Prevent them from infection. Number 4, everyone should know curling ulcer. In the stomach, they get the ulcer, which is called curling ulcer. Anemia. And also they have, remember, we did earlier, DIC. And potassium level, I said already, DIC, and monitor for anemia. So everyone should know something on your patient with burn. Your technique are sterile. And remember, what do you put it on the bed? It's called cradle. Cradle word. Cradle, you're protecting the patient. So we'll stop here for today on page 11.